Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline 3 is where we like to focus on ways to help you live a healthier, happier, and pain-free life. We'll also be taking your calls and answering any of your questions that you have today live in the studio. But before we open those phone lines, it's always good to remind you to make sure you're in a quiet room when you call. And if you're listening via TV, maybe turn your TV all the way down so that we can hear your question. That number to call is 318-219-4569. When you see it on your screen, that means those phone lines are open. Today's topic is peripheral vascular disease, and joining us today on Healthline is Dr. Eaves, interventional cardiologist with Willis-Knighton Cardiology in Bossier. Thanks for being here.
Thanks for having me.
Absolutely. Yeah, so first tell us a little bit about what you do as an interventional cardiologist. Is this like a step you had to do maybe some extra training to be an interventionalist?
Well, actually, I'm back when I trained with the dinosaurs, we didn't have an extra year. Now they do require an extra year. So I just kind of came on the cusp of that. And so interventional cardiology refers to manipulation, doing procedures on the coronary arteries, doing angioplasty, which is the balloon procedure, and then placing stents and so forth. And so through that, kind of had a partner that had started doing a little bit of peripheral vascular disease, kind of doing a little bit, and then I went down south and started getting into it and training up. And so it's been a huge part of my practice for, gosh, the last 20 years or so.
Wow, okay. And so you're able to do a lot of maybe these procedures that would help with peripheral vascular disease, which is what we're talking about today. So first, tell us, what is peripheral vascular disease? So
peripheral vascular disease affects, according to who you look at, somewhere between 10 to 15 million Americans. And it's the number one cause of amputations, probably more so than even trauma, which is really sad. And in the past, before we had operators that were aggressive on treating it, you'd have a lot of folks that would come in, have a wound on their foot that wouldn't heal, and they'd end up losing their leg. And of course, once you lose your leg, the mortality rate over the next 5 years, probably 50%. You have all this problem with mobility. And of course, it's from a human being standpoint, to lose an extremity is a pretty traumatic event.
Right, yeah, and so we definitely want to maybe recognize those signs and symptoms so that you can get ahead of it before it gets to that extent.
Absolutely. So the people who are at risk are the people who are at risk for any type of cardiovascular disease. That would be people with a family history of, say, coronary disease, those with high cholesterol, those who smoke, diabetics, hypertension. So all the general stuff that you would do to try to lower your risk of having a heart event would be the same thing that you'd want to do for peripheral vascular disease. The symptoms of peripheral vascular disease classically is called claudication, and that would be cramping or fatigue, tiredness in the muscles when ambulating. In extreme cases would be, say, a wound on the foot, coldness of the foot, loss of hair growth on the lower part of the leg. Okay,
and you mentioned diabetes being one of those things, and I think about when you have uncontrolled diabetes, if you have a wound on your foot, that already causes that non-healing wound, but then I'm sure it's not any better if you have both of these together.
Well, interestingly, so there is that, if you have uncontrolled diabetes, of course, you have all this glucose, and it's just a substrate for bacteria to grow and thrive and so forth. But almost always, if you have severe diabetes, you're going to have some degree of atherosclerosis, typically in the small blood vessels. It's having those high levels of glucose causes inflammation, and so there's a progressive deterioration of the arterial function and so forth.
Makes sense. Okay, so I mentioned this to you before we got started, but let's have a little anatomy lesson, if you will.
Okay, sure.
And we know we have veins and we have arteries, but sometimes we forget they serve two different purposes.
That's right.
And they probably play different roles when you're diagnosing.
They absolutely do. So arteries are the pipeline that brings blood, oxygen, and nutrients to all of the tissues of our body. That's where we measure our blood pressure, so it's a high pressure system. The job of the veins is to take that blood when it gets and delivers its oxygen to the tissue to bring it back to the heart so that it can circulate through the lungs and get reoxygenated.
Mm-hmm.
And they are related but different entities kind of altogether. Typically somebody that has a common problem that you see is people with venous insufficiency, where the veins don't function as well and the blood tends to pool in the lower extremities, so there's swelling, redness. Sometimes they can actually get ulcers as well, but it's a little bit different than the arterial, and there are treatments for those as well. I do treat deep vein thromboses. Sometimes people go on a long trip or immobilized from surgery and so forth can develop a blood clot in their leg.
Mm-hmm.
And many years ago, all that was offered to a patient was to be put on blood thinner. But if the clot is above the knee, 50% of those people will have lifelong complications from it. It never completely resolves. And so we're able to, through a variety of different techniques, actually be able to go in there and remove that clot.
Gotcha. Yeah. So you mentioned long trips. So if you're, on the airplane or something, that's why it's important to be able to stretch and move.
Absolutely.
Yeah.
I guess the best tip preventing that if you're on a long trip, not only move around a little bit, but our calf muscles are the pump that pushes the blood back. So even if you can't get up and walk around, just doing some calf raises, raising your heel up will activate the calf muscles and tend to push the blood back up to the heart.
Something that maybe people need to think about going into the holiday weekend if you're going to spend long hours in the car, like I will be doing this Saturday.
Right.
So
well, and two, when it's very hot, if you're very dehydrated, that can play a factor as well. So stay hydrated, walk around, move around a little bit. So.
Okay, good tips. Well, if you're just joining us, we have those phone lines open. That number to call is 318-219-4569. We're talking with Dr. Britton Eaves with Willis-Knighton Cardiology in Bossier, and we're talking specifically about peripheral vascular disease, but you also treat the deep vein thrombosis, and I think we didn't mention the pulmonary embolism. Is that something else?
Yeah, thankfully within the last, I would say 10 years, we've got several devices and techniques that allow us to treat those. That's a potentially fatal complication. A lot of times people who have been immobilized from sickness, from surgery and so forth, usually start off, develop a clot in their leg, and then it propagates up to the lungs.
And that can happen really quickly, right?
Just in a blink of an eye. So.
Wow, yeah, so definitely can be scary, but thankfully technology has improved.
Oh yeah, that's been a huge benefit. We've got several technologies and techniques that we can use to treat those. Nice,
nice. Well, going back to the peripheral vascular disease, what are some of those signs? And you mentioned some of the signs and symptoms, like the cool to the touch, but is that when it's pretty severe?
Usually it is, and there can be other reasons why people who have cold, you hear people all the time say, my feet are just ice cold. But the thing is, if you're concerned about it and you have some risk factors, there are some fairly simple tests we can do as a screen. The most common, if you go see your doctor, we can do what's called an arterial brachial index. And so more common that you would have blockages in your legs than your arms. So what we do is we measure blood pressure in the arm and then a blood pressure at the ankle and divide the ankle by the arm blood pressure. And if there's no blockages, it should be 1. The ratio should be 1. So if it drops down to 0.8, and below that, there's a pretty good chance you have significant peripheral arterial disease. So.
Gotcha. And this is something that you would mostly see in the extremities, because is that because it's the furthest away from your heart, or?
Well, I'm not. No, I mean I think it's just the same process. But now as to why we rarely see it in the arms, I don't have a good answer.
Okay.
For that.
Yeah, I was just curious. Yeah. Well, and there's no telling. There's probably many different, but the science shows and the studies and the patients that you see that it is most commonly found right in
for sure. Like I say, it's a common cause of amputation. Sometimes people lose toes and so forth. And it's a real impact on their lifestyle and ability to go out and do the things that they want to do. That's really why I got hooked into doing it, because you know, you see these people that they walk to the mailbox and they have to stop because their legs are cramped, or they hang their legs off the side of the bed. You relieve that, or certainly if you prevent somebody from having an amputation, I mean, you really impacted their life. So it's really good feeling. I mean, you know.
I'm sure. Yeah, I'm sure it feels rewarding, and like you said, you've made a difference in their life, and it's basically immediate. I'm sure as soon as they recover from the procedure, it's an immediate relief.
Oh yeah, it's a huge impact on their life if you're, you know, in pain all the time. And a lot of these people are in pain all the time. And that's the other thing I would mention is, so classically the symptoms are claudication. In other words, someone who gets out and exercises, or even just walking, and they may have cramping in their calves or pain or so forth. But a surprising number of patients will be certainly if you go by that criteria, they would be asymptomatic. You know, people tend to, you know, as they get older, they tend to accept what's going on. Well, I'm just getting old, I need to exercise more. And so sometimes it'll be really maybe a symptom of leg heaviness or weakness in the legs, or just not being able to get around. And sometimes people say, well, you know, I'm just getting older.
Yeah.
But if you have the risk factors, like I said, high cholesterol, hypertension, family history, coronary disease, elevated cholesterol, then, you know, it's worthwhile to get a screen and get looked at.
Right, and you mentioned the cramping in the calves. Does it feel like a muscle cramp typically?
Right, and you know, people get muscle cramps at night a lot, and typically that's not associated. That's usually an electrolyte problem.
Right.
And so that's not, we're talking about more associated with walking, you know, using the legs.
Like the example you gave with walking to your mailbox, and if it's hard to even make it that far, because it's you can notice it almost immediately after just a couple of minutes of walking.
Yeah, it depends on how severe it is.
Oh, right.
And you know, a lot of these people also have other issues. They may have arthritis and or back problems, and say, well, it's from that. So if you have a question about it, the best thing to do is just get it checked out.
For sure. Yeah, and typically with cardiologists, would they need a referral from their primary care, or could they reach out to your office directly?
I think they can reach out. You know, I'm not going to lie about that either. That's why we have office staff. Sometimes I'm the, you know, play dumb on it. But yeah, as far as I know, they don't need a referral. I mean, it's what we're passionate about. So
for sure, yeah. So do you have a phone number that someone could call if they're interested?
Sure.
Yeah.
Well, we're at my office at Willis Knight in Bossier, and our number is 747-3494. But certainly we're in any kind of directory. Right. And so, absolutely, we'd love to hear from people. We work with a lot of wound care doctors, you know, because the wounds won't heal if they don't have enough blood flow to them. So we work with them. Work with podiatry a lot, because, you know, a lot of times people come in and, you know, with a problem, well, you know, I just had a little sore on my foot, and the podiatrist looks at it and goes, this is more than a sore, there's an issue here. Notices, you know, that there's reduced pulses, or that the foot is cool, or and so we work with them as closely as well. Always worth getting it checked out, even if that's starting with your primary care or reaching out to these guys directly as well. You know, it's a multidisciplinary, you know, because we need all the medical disciplines. Like I said, we work with wound care, we work with podiatry, primary care. Of course, they're the ones that are going to be the front line on, you know, identifying the disease, number one. Number two, controlling the blood pressure, controlling the glucose, lipids, all those things. So it's a group effort. For sure, yes. Okay, so so you are a part of the intervention side of things. So tell us a little bit about, you know, maybe these advancements you've seen in treating something like peripheral disease. Okay, yeah, it's really come a long way. So when I first started doing it, we had, you know, balloons. We had some stents, but they actually weren't FDA approved to put in the peripheral vascular space. And then we had devices that could cut some of the atherosclerotic plaque out. Since that time, we've, you know, well, yesterday I used balloon stents, lasers. We have a device that actually delivers intravascular lithotripsy. Same technology that breaks up kidney stones we use in arteries that are heavily calcified. and that's probably our newest kind of game-changing technology. And actually yesterday I had a patient with severe renal failure, and so we did the case with CO2. We used CO2, which is kind of crazy when you're injecting a air-filled syringe, but it was CO2. Huh. And the bubbles you could see, it didn't damage the kidneys, and actually it'll circulate through the body, and when it makes it to the lungs, it's exhaled.
Wow, that's pretty cool.
Mm-hmm.
That's awesome. So, in some of these, are they mostly non-invasive procedures?
No, they're all invasive,
Okay.
but they're all through catheters.
Okay.
You know, so.
So you're not cutting open a bunch of.
They don't allow me to have too many sharp objects. So I do all mine through catheters, either through the groin. Sometimes cord, if it's complex enough, sometimes we have to access the artery in the foot actually and work that way.
Wow.
Sometimes we have to go have the patient lay on their stomach, come from the behind the knee.
And how are you deciding that? Do you have these tests, any tests that you run where you're looking and getting a game plan?
The great thing is once we get past the ABI identifying it, we do several non-invasive tests. Really our kind of workhorse is the ultrasound. So we get the tech to ultrasound. They can give us a pretty good idea. Actually, it's not unlike what your weather guy does with Doppler signals. We use Doppler all the time, and the way we do it as a vessel is narrowed, because it's just fluid flowing through there. It has to accelerate over that blockage because it's narrowed, and based on what that velocity is, we can get an estimation of what the stenosis is. And then based on that, sometimes we might order a CT angiography, which is a CAT scan that they give contrast, and it delineates all the arteries, so we get sort of a road map before we go in there to do the case.
Makes sense. Yeah, kind of like a blueprint for you to see where things
right,
are.
Right, and that a lot of times will help us decide, well, gosh, I can't go this way, so I need to do a different access point. So
I know in some cases, if you're looking at someone's, like a CT scan of their arteries, and it comes back maybe, let's say 60% blockage, 80% blockage. When do you typically say it's time to operate?
Well, a lot of it is based on their symptoms, but we get a pretty good idea from the scan. Honestly, usually by the time, particularly if we're going to a CTA, we've already made the diagnosis and feel like, sometimes we do it to confirm and say, well, everything is okay, but so we start off basically by their symptoms. We do the ultrasound, CT if we need to. But in general, since you asked specifically about stenosis, going back to what I mentioned about velocities and so forth, I think I'll probably say it wrong or be incorrect. I think it's Bernoulli's equation or something, like throw the old physics in there. But so flow requires about a 70% reduction in the diameter before there's a significant pressure drop on the other side.
Gotcha.
So we use a 70% criteria for most of the interventions, whether it's coronary, peripheral, cerebral vascular, any of those.
Gotcha. Okay. Very interesting. So we've also spoken with your colleague, Dr. Sugar, before.
Oh yeah, he's a great guy.
And I love the way he described, because we've talked about something like I think peripheral arterial, but he kind of describes himself as like a plumber.
Yeah.
You're kind of going in and cleaning out the piping. Would you say that's pretty accurate?
That's pretty accurate right there.
Okay, I love it. Yeah, and I mean, but we need guys like you to do that kind of stuff. So
well, we need guys like him. He and I work closely together because we have to, as I said before, it's sort of a team effort. And he is smart enough and skilled enough to use sharp objects and scalpels. So there's many times, we may do a combined procedure.
Cool.
Where I do part of it, and I say, well, this is better served, this portion of it surgically. So we have a really good working relationship, and I'm really happy that he's in our system. So.
Yeah, that's pretty cool. So let's say, I'm sure it depends on the type of procedure that someone is receiving, but what is the recovery like with something like this?
It depends. Many times because we're doing it through the just a catheter, an intraarterial catheter, not unlike the IV that you get, just slightly larger. So, what I try to do is when I get done, we actually seal it up. If we can do away with the old where you had to do the manual pressure, and a long time ago we had to put sandbags and all this, if we can seal it up, that's what we try to do. And when we seal it up, we send them home the same day.
Wow. And
kind of take it easy for a day or so to just make sure there's no problems with the site, and they can go on about their business with hopefully dramatic improvement in their ability to ambulate and exercise, enjoy life. So.
Yeah, and hopefully knowing that they've had this diagnosis and we fixed it, do you see a lot of your patients change their lifestyle as well to manage their condition?
Some of them do, some of them don't, but we're there for them all the time. But we certainly encourage that, and again, so we don't just fix it and send them on their way. We try to optimize the control of their cholesterol, get them to see their primary. If their diabetes is out of control, obviously we, under cardiology is hypertensive control, so we do all those kind of things.
For sure, yes. Okay, so we were also talking about, I guess, deep vein thrombosis. Is that similar to like a venous blood clot?
That's exactly what it is.
Thing? Okay, and how common is something like that?
Well, it depends. There are certain segment of the population that have coagulation disorders, and surprisingly, sometimes those people can go for quite a while without having any issues. But that's a relatively small. It's probably not as small as we once thought it was. But people in general, like I say, will have them just pop up kind of all out of nowhere after a period of immobility, whether that's a long drive, long airline trip, maybe they've been sick and kind of had to be bed bound for a minute, or they've had recent surgery and recovering from that where they've not been up and walking.
Right. And
so those can develop pretty quick. There's also it's called venous compression syndrome. Believe it or not, we mentioned that the arteries are a high pressure system. The venous system is relatively low, and so the arteries are pulsatile. You can feel, that's why you can feel your pulse. They're thick and muscular. Veins are kind of thin-walled and easily compressible. So when the aorta comes down and the vena cava is coming up, they both have to cross so that they can get to each leg. And the artery can actually, the iliac artery can actually compress the iliac vein and be a cause for blood clots or chronic swelling in the leg. And so in those people, we go in and we run an ultrasound probe actually inside the vein and see if there's compression there. We can put a stent there and completely fix that. So.
Wow, how do you find out that you have that?
Well, just symptoms. Symptoms. Sometimes people have kind of episodic swelling in one leg, and maybe they go in, oh my gosh, I got a blood clot. And sometimes sometimes I've seen people that have been evaluated multiple times, multiple ultrasounds, and they didn't have a blood clot. Well, what was happening is the actual blood flow was being obstructed in coming back to the heart. So that's usually where we see that is people who have, and it's going to be one leg. If you have both legs that swell, typically that's from maybe too much salt in your diet, could be related to some problems with the kidneys, some problems with the heart. I mean, that needs to be at least, evaluated, but it's going to be one leg that's more swollen than the other leg. So we'd start off on that with an ultrasound, because the number one thing you want to rule out is a blood clot there. But if the blood clot's not there and you don't have another good explanation, it's worthwhile to evaluate to see if you've got some venous compression.
Gotcha. Okay, and so since you say compression, of course, I think compression socks. Are those
helpful? Well, not for that one, because you've got a mechanical obstruction up higher up, and until you until you resolve that, that's not going to resolve. But a lot of folks, and that's another reason why you might have swelling in both legs. Not uncommon for people to have venous stasis disease. Typically those people have swollen legs, and they may have some visible veins, they may have some varicose veins, and the compression stockings help that a lot. The only problem with that is they are, especially living in Louisiana, they are hot and they're somewhat difficult to get on. I don't treat superficial venous disease, but there are people in town. That really is something that, in general, our medical community probably needs to kind of shore up and have that available, because, if you're walking around and your legs are these, I mean, that's miserable, because they're heavy. They typically going to get worse with older people, so now they got these heavy legs. They're at higher risk for developing cellulitis, which is infection of the skin, and so.
Interesting. Okay, so let's say that someone is maybe maybe they know they have some of these risk factors, and they know they have the high cholesterol, they know they have diabetes, they smoke, have hypertension. If they could focus on one thing today, what would you say is, because sometimes it's hard to change it all at once, what would you say is the most impactful thing to change?
Well, I'll just start at the correct answer is all of the above.
Right, of course.
But if I would go to I would say smoking.
Okay.
Because smoking is a huge risk factor for developing peripheral vascular disease, and also a huge risk factor if you were to have a procedure, and even if you got a good result, if you continue to smoke, your odds of recurrence are dramatically increased. And that's something, although it's incredibly hard, obviously, and I'm certainly not, diminishing that to quit smoking on your own, but that's something that you can change. The second big thing is, if you have diabetes, would be to get that out of control, because diabetes is a huge risk factor for all kind of health problems.
Right, yeah, like you said,
followed closely by cholesterol.
Okay, yeah, but all of the above, of course. But yeah, so it's sometimes easier to maybe focus on one of those things. But that's what would be helpful, to talk with a team like you guys to help support the patient, because sometimes it feels a little overwhelming to do it by themselves.
Sure.
But if you've got that support, maybe with medication, and other people cheering you on, it always seems like it helps.
For sure.
Yeah. Okay, well, we have just a couple of minutes left. So one of the questions that we have is, are you involved with any research trials?
Yeah, I'm fortunate. We've done probably 6 or 7 trials for FDA approval of devices. We have an ongoing trial right now, and certainly in the process of people wanting to be evaluated for peripheral vascular disease, we'd love to hear from them, because we do have research trials going on, which has been nice. We get access to some things sometimes that are not completely released, but that's, and we also do some drug therapy trials as well. But it's been a lot of fun. There's some major trials that really impacted the field of peripheral vascular disease that our lab over at Willis Knight and Bossier would be one of, say, 30, 35 sites in the United States to be part of that. And
that's
so
awesome.
That's been fun.
Wow, well, that's awesome. So if someone is wanting to, I know we mentioned it earlier, but let's throw out that number and where you're located at again for our viewers.
Okay, my office is at Willis Knight and Bossier. And I know there are other numbers, but that's the only one that pops in mind, 747-3494. But of course, if you looked it up online, it's very easy to find. We'd love to hear from you, because it's what we like to do.
All right, well, thanks for joining us, Dr. Eaves. And if you missed this conversation, it will also be posted on our website. That's ktbs.com/podcast. And we also have this on Spotify. So if you like listening to podcasts, you can listen to this episode and other episodes from Healthline 3. Thanks for joining us.